So now we're going to do the pulmonary assessment, and for the pulmonary assessment, we're going to be using, of course, the stethoscope, and the only part of the stethoscope that will be valuable for pulmonary assessment will be the diaphragm, because if we, at any point here, any adventitious breath sounds, it will be high pitched, so it will be heard best with the diaphragm. So the bell is not useful for pulmonary assessment. To start, the order will be inspection, palpation, percussion, and auscultation, but for the purpose of this exam, we're going to avoid palpation, so the only thing that we will do will be inspection, percussion, and auscultation. So for inspection, you stand in front of the patient, you basically tell the patient, can you please raise your chin and look at the patient's neck to see if you are at any point see any tracheal deviation that could indicate, for example, a pneumothorax. During this exam, we're not going to undress the patient, but you can take the patient's gown and look at the intercostal space and see if you see any type of retraction. You can also look at the sternocleidomastoid that could indicate that the patient is using accessory muscles for respiration. Again, indicates shortness of breath. You can also ask the patient any type of shortness of breath or cough.
No.
Okay, can you please take a deep breath for me to look for the symmetry of the chest rising during inspiration. Then after that, we're going to do percussion, okay? So because we have the mediastinum, the breast, and the heart superimposed, the percussion of the rest of the chest would be not valid. So we're only going to percuss at the level of the second intercostal space. And remember, the intercostal space are horizontal. So you're going to basically use the middle finger in the intercostal space of the non-dominant hand. This is the dominant hand is going to be your percussor hand, and never rest the palm of the hand on the patient's chest or back to avoid any flatness or dullness. So basically put the finger in the intercostal space, like you're going to use either 2 fingers or 1 finger as percussor. And you're supposed to hear resonance. That's the normal sound during percussion. Then, since I'm standing in front of the patient, I can do auscultation in the front and then proceed to the back and do the same order, percussion and then auscultation. So I'm going to auscultate the patient's anterior chest, again in the second intercostal space, using the diaphragm. Please take a deep breath in and out through your mouth. Okay, when you auscultate the front and the second intercostal space close to the sternum, what you're supposed to hear is bronchial breath sounds, and that is completely normal. Then you tell the patient to please turn to the back. And you're going to do percussion in the posterior aspect of the lung. Again, never ever percuss on top of the scapular area, because you're going to hear flatness or dullness, and that is not the normal resonance that we're expecting to hear. So you're always going to percuss and auscultate interscapular and out, and always in a ladder pattern, as we explained in class. You start through the right, left, down, right, down, left, down, and so forth. So you're going to see me doing that now in a second. Again, remember, intercostal space is horizontal. I do not want to see any student putting the finger perpendicularly or vertical, because you're going to be hitting on the ribs, and that will give you a wrong sound, which is dullness or flatness. What we are expecting is resonance. So again, horizontally, and that will be the end of the percussion. Again, I am supposed to hear resonant sounds, which are completely normal. Then I'm going to auscultate in the same ladder pattern. I'm going to ask my patient that every time I touch you with the stethoscope, you're going to take a deep breath in and out through your mouth. Okay? Take a deep breath. And this is the end of the pulmonary examination.